Hello, everyone. We are on our club webinar number 91. Great topic came in. Looking forward to talking to you about it. It is what do we do when we're coding for long-term effects or sequelas of COVID-19? Now, you're going to see a lot of education out there regarding the codes for COVID. And, last year it was something that never happened before that we got a code dropped early and in the middle of the year. Um, then they started making changes to the codes that they added. And several things that I'm going to show you today are going to have information before a specific date and after a specific date because they made changes. So I want that to be in your mind. And I didn't really spend a lot of time making this pretty and foo-foo-y for you because it's a lot of content. However, I did put all of the links that I got the information from in the resource slide at the very end. And, I my thought process with this presentation was a little bit different because again, I want to get the information to you and then we'll talk about it and then you'll use that as always as a stepping stone to do more research. This is now one of the topics that we're seeing out in the medical field predominantly. Now that we've kind of gotten through the whole COVID uh, incident, we still have cases, but it's been a significant amount of time that we're starting to see what's the long-term effect, what's the sequelas of people having had this virus. And again, we're probably going to learn more in the next few years and even a decade from now. We may see some information pop up as we understand this particular virus, just like when we had other SARS viruses in the past and different types of flu. Remember, we had swine flu, bird flu, and all of these. We know more about the long-term effects of those since with time. That's just what happens, right? Time helps us understand. So I wanted to go over some basic definitions for you. The term sequela is just means late effect. Ultimately, that's what it is. Some people say late effect. Some people say sequela. I like to say sequela because I think it's a pretty cool word. But ultimately, if you look over here at the purple box, you'll see that it states it's a long-term, late effect of an infection, but it could be other things, a condition which the consequence of a previous disease or injury has occurred. Now, look at the green box to the left. Sequela a lot of times refers to a chronic complication of an acute condition, and they will use that as also synonymous with long-term effect. And now look at the difference though. It says sequela is different from a late effects because those can appear long after several decades where the condition is originally resolved. So late effects and sequela in our world really is synonymous, but if someone were to break it down and say, well, actually, it's two different terms. But for us, sequela hit the verbiage in the ICD-10 manual a little later than late effect, if you've been around as long as I have. So let's look at some other definitions. When people start having complications of the COVID-19 over an extended period of time, they started coining this phrase called long COVID. Now, there's some other terms that they use, but this is the one that seems to be sticking. And so I suspect you're going to see this in the documentation if you aren't already seeing it and then seeing it, in the future. Again, we have different ways that we break down and try to make definitions shorter, that we abbreviate things in odd ways. I know you guys have seen that happen too. So again, long COVID is here to stay, that term. And it really, you notice in the purple box, it's the post-acute sequela or long-term symptoms that are experienced weeks or months after a patient is tested positive for COVID-19. Now, the primary infection that causes COVID-19 is called SARS-CoV-2. Uh, I just threw that in there too because I just attended a lecture yesterday for rheumatology providers, and it was a symposium. So all day they talked about this MIS that we're going to talk about here in a little bit, and most of it was based on the long-term side effects and the studies that are happening with their patient with immunosuppressant disorders and COVID. Um, Again, the statistics, I wouldn't worry about those too much, but I did leave that in there for you to look at if you wanted to know more. Whenever we're dealing with long-term effects, make sure that you see the documentation from the provider that they have linked the signs and symptoms to a history of COVID, right? That this is a post-COVID status, signs and symptoms. Otherwise, they're just regular signs and symptoms. Now, there are some specific uh, diseases that we'll talk about, as well as some specific conditions like pneumonia that are associated. Okay. Now, I'm not going to read off all of these signs and symptoms, but these are the ones that came out listed from the Mayo Clinic as signs and symptoms that of people that have post-COVID lingering um, documentation that's stated for them. None of these are a real diagnosis or another disease in and themselves. Almost all of these are R codes, and we know R codes are signs and symptom codes. Now, I'm going to tell you how we would code that later, but again, the provider has to link that. Just because a person has a loss of smell or taste, uh, that, of course, we synonymously think of that as COVID now because that was one of the first links that they made as signs and symptoms, so now everybody talks about that. But I want you to make sure, again, I can't reiterate this enough, just because that's stated, and even if they state the patient has a history of COVID in the past, they recovered from COVID, that does not mean that that is linked unless the provider links it. This kind of goes back to the past when we used to do comorbidities with diabetes, right? The causal effect and relationships with diabetes, that, a patient didn't have diabetic polyneuropathy unless the provider stated that the patient had diabetes with polyneuropathy, and or diabetes and polyneuropathy didn't link. And then they changed that, right? So again, all of these are signs and symptoms that have been associated with lingering after COVID-19. However, without that thread from the provider, that verbiage, then we don't link them. And Donna said, yeah, brain fog. That's one that that's definitely in there. And you know what? I just thought of another brain fog. You know, that linking of people that have had cancer and been on chemo, and they talk about the brain fog. That is a sign and symptom, a lingering sequela, often associated to chemotherapy treatments. So again, if the provider doesn't link that, even with cancer treatments, then it isn't. Maybe the patient's just older and has age-related senility. So, okay. Organ damage is what Mayo said is coming up as problematic for people, some people that have COVID. Now, just because a person has COVID or recovers from COVID-19, it does not mean that they will have these side effects, these sequelas, or organ damage. However, there is some long-lasting links, and they said long-term breathing problems have been linked, as well as heart complications, kidney impairments, not necessarily CKD, stroke, Guillain-Barré syndrome. And Guillain-Barré syndrome, if you're not familiar with that, that's pretty fascinating. I've read some books about people that have had that, and how that develops. It's wow. Again, go do research on that if you haven't done so. They could also have multi-system inflammatory syndrome, which is MIS. And this lecture symposium that I attended, they talked a lot about MIS. So MIS-C is children, and MIS-A is in adults. Uh, it, I don't know how long that's been a diagnosis. I didn't really look into it anymore than to know that it is a condition where different parts of the body get inflamed, organs get inflamed, and it takes a while for the body to process that. Really in-depth lecture on treating that and the labs that show up, all the way up to lipid levels, and it was fascinating to see that. But it directly linked, they were saying, as people that had things like rheumatoid arthritis or Kawasaki disease, and they got COVID, and then they developed MIS afterwards. Again, it's pretty dramatic and interesting information. Our basic code for COVID is U07.1. Now, that is a current case of COVID-19. Now, there is sequencing rules and things, but now we're not going to talk about anything other than late effects or sequela, because if we talked about, well, first of all, we've lectured on other stuff, but we would be here all night if we talked about those. So the basic code itself is U07.1, and this year they did change the description. So know that there were changes in the long description, and you're going to use any additional code that would identify pneumonia or other manifestations for a current case of COVID, right? That's um, um, things like the patient gets pneumonia due to COVID. Now, that's a current case of COVID, active COVID, tested positive. They develop pneumonia due to that. That'd be a J12.82. If it's after COVID, that's a different code. And then there's excludes. So we know that there's other types of coronavirus. That's a B97.2 code. Just unspecified coronavirus, the B34.2 coronavirus unspecified, is not COVID-19. And then pneumonia due to SARS associated coronavirus, J12.81. Again, there's more than one type of SARS. The SARS that COVID-19 is 2, and there's a SARS 1. So just keep that in your brain. Now, if we are going to work with sequencing, we want to always know that you'll always see that there's a specific code for patients that are obstetric patients. There's an O code for having complications of a viral disease. We're not getting into that. But the U07.1 is always a principal diagnosis. It'll be first listed, and then after that you would list the other things that are complicating it or other conditions that the patient has. If you have any manifestations or symptoms, they would go after the U07.1. Now, there was some additional information about sepsis, and that can happen, but those are dealing with current cases. We're not going to talk about those. predominantly our thought process for this lecture is that the patient had a history of COVID. Now they're seeing long-term effects after that. So that code that you need to be aware of is Z86.16. It's a personal history of COVID-19. Now, if you have follow-up visits afterwards, so the patient had COVID, they're doing good, but the doctor wants them to come back, then so that they could still check on them, then you're going to use a Z09 code. So, and then you would code the personal history, the Z86.16. The patient had COVID, the provider wants them to come back and check on them, especially maybe because they have other conditions. Maybe they have COPD or diabetes or something that could be problematic. Maybe they just weren't recovering well and they want to know that they're doing okay. So they're having them come back. That's a Z09. And then why? Because of Z86.16. So be very aware of that. Vaping is a different code, Jane. That is U07.0. And what they did was when they added the COVID code, and then when it rolled around for the time to add the codes officially, the new codes, they added the vaping code. So it is a different code. Now, we could have a patient that comes in for antibiotic testing. Now, it doesn't matter if the patient is not had COVID, a positive COVID test, or this could be after a COVID tested positive and they have them come back. Are you still testing positive for COVID? So encounter for that antibiotic test is a Z01.84, right? So have that written down in your little notebook or knowledge bank. But if they're being tested to confirm a current case, okay, of there are applicable guidelines to that. So after COVID-19, you're going to look in your guidelines at IC1G1J, and that was the one we just looked at before, the previous slide. MIS. Now we talked about that, and that's pretty prevalent. That's common. So you may have have any of you guys seen this MIS coming through in the documentation with patients that you're working with? I'm curious to know because the rheumatologists, of course they're specialists, and they had, Boston was there, and some specialists out of Children's in Texas and St. Louis, and MU was University of Missouri, who was hosting this. But it was pretty fascinating, all these specialists that they had in the symposium. It was kind of eating all that up. Took lots and lots of notes. So if we have MIS and they have COVID, you're going to code the U07.1 because that's the current, right? And then they have MIS, so that's the M35.81. Now, that's if it's current. But what if they're not current? What if they develop the MIS after COVID? Let's look at that. Then you're going to use the M35.81, and the next code will be the B94.8 because it's a late effect of specified infection or parasitic disease, which would be COVID-19. So M35.81, late effect B94.8 is the proper way to code that. Now, if then you could also put the history of COVID in there. That would be applicable. So again, what did the patient have? Well, they're a history of COVID. But there's not a code for sequela or late effect of an infection or parasitic disease. It's a very broad umbrella, but how do we tell the rest of the story? We put the Z code in there to identify it. So you have a history of COVID, they get MIS, and the provider does not say that the MIS is due to COVID. That's different. Oh, wait. it does not indicate the MIS is due to the previous COVID infection, then it's the M35.81, and then you've got the history of COVID, the Z86.16, but they didn't link it, right? Whereas previously, this is linked. It is a sequela for COVID, right? But this is stating M35.81, they've got MIS. Oh, by the way, they had COVID, but we're not saying that it's a sequela. The MIS is a late effect of the COVID, just by the way they had COVID. Again, important to understand the difference there. Okay, now let's talk about we know or suspect exposure to COVID, but they don't have a current COVID infection and they get MIS. Then what are we going to do? Well, of course, we've got our M35.81, that's our MIS, and then you could use the Z20.822 because they've been suspected contact or exposure. And then you can go ahead and list anything else that would be complications of MIS, right? But we don't have a current case of COVID right now, right? So that it's not a late effect. We got to be very careful. All right, now I've got some interesting things. Now, the B9 4.8 notice in the green box, and I wanted to make this font big enough for you guys so that you can see and make it easy to read and be able to take notes, because if you're in our CCO club, you get to have access to this slide deck as well as the recording, and you also can you'll be able to make notes for yourself and discuss it over in the club. But so I went ahead and just circled these in green so that you'd be able to see them a little bit better. B9 4.8 is late effect of that infection, and you could have a prolonged hospitalization rather than being a late effect of COVID-19. That could be applicable to that as well. So this scenario is you have a patient, and let me backtrack real quick. These are Q&As, frequently asked Q&As that came from Find a Code, and we pay for the additional articles and things that came through. So some of these are quoting clinics and some of them aren't, but I went ahead and made sure the resources were on the resource page. So if in fact, again, you have access to the club, you're going to have access to all of this so you can look at your notes again. So this particular scenario was you had a patient that's transferred from acute hospital care and they send them out to rehab, and they had a long hospitalization because of COVID, and it's all resolved. They don't have COVID anymore, right? Then what are we going to do? Now here, remember I said you're going to have two different dates. So 7/22/2020 versus 12/11/2020. There are different codes that were used because they kept revising and updating the code. So those dates are in there. You're probably not going to have to think about those older codes unless you're doing risk adjustment or for some reason where you're doing something where you're looking at anything prior to January 1st. You're doing some audits or something, but I left these dates in there for you for your notes. So they say, what do we do? Well, they said, for example, we have generalized weakness, that you're going to code that history, the Z86.19, if it's before January 1st, because that's the code they told us to use because they didn't have the personal history of COVID. But then after that, we now have the official history code for COVID, not that generic infection parasitic disease code, and it's Z86.16. Now, if you see those used, that is a flag for, hey, this was an encounter that was prior to 2021. That's 2020's cases. And then in 2021, we were able to use that new code, Z86.16 versus 19. And it said the personal history code for the discharge and stuff as a secondary diagnosis for that patient. So another question that came up was, okay, we have a child, they had COVID several weeks ago. It could even be like last month, and they get admitted for MIS-C because the C is for child, and that MIS is a directly related to the provider documented it's due to the COVID-19, but they don't have COVID-19 anymore, but they have developed MIS. So what are we going to do? How are you going to code that? Because that would be a late effect of COVID. So the M35.8, that is going to be the old code for MIS, but now they've updated it just like that history code. We now have M35.81 for MIS. Okay, and it doesn't distinguish adult or child, it's just MIS. And that'll be the principal diagnosis for the MIS, M35.81. Then you're going to append also the late effect code B94.8, as this is the secondary diagnosis because it's a late effect of COVID-19. They got COVID-19, they got through COVID, but as a result, the sequela is M35.81, MIS. And this could definitely put them back inpatient and ICU. Okay. Now, if this is just a little caveat, if that provider though doesn't link those, then you're going to end up having to query to find out that if it's specifically due to the COVID or is it due to something else, like the patient had rheumatoid arthritis, and they have an immunosuppressed disorder. Donna says, I have seen critical illness myopathy used for post-COVID-19 rehab patient admissions. Yeah, that is also one that I heard them talk about. There's a lot of myopathy conditions that were popping up. And so that myopathy would be first, and then the B94.8 is the code for the sequela, right? Moving on. Okay, so then what if it is an inflammation of the veins? If you've got a thromboinflammation, or they call that associated coagulopathy, I guess is well, if they have current COVID, then you're going to use your UO 7.1 and then the D68.8, which is, hey, they've got a problem with the coagulation defect. There is a DIC condition, disseminated intravascular coagulation, that's a D65, but they made a point to stay, and they're linking this. They're saying, this is not MIS, it's a little bit different, but it is a problem with coagulation, and our current and post-COVID patients, they just note that they said, just because it's COVID-19 does not mean that they have DIC. Okay, so again, it could be D68.8, which is other, and other is defined by the code set as, hey, we have definition, we have specificity by our provider, there's not a code for it, so we use other, D68.8. If it's disseminated, then it's a D65. And another question, what about skin failure due to this complication of the coagulation, and it's a microvascular changes, and it's due to COVID? Well, again, if it's current COVID, it's UO 7.1, then you would do the D68.8, and then you would append L99 because that is other skin disorder. This is new. There's not a code for that. However, if in fact they don't have COVID anymore and it's a late effect, what are we going to do? We're going to drop the UO 7.1, and then we'll have the D68.8, the L99, and then you'll have the history of COVID code that the provider is linking. Can you use R79.1 for blood coagulation? No, not in this scenario. You would not do that, Jane, because it is saying that it's due to that underlying cause of COVID, and that's unique. That's different. It's not normal blood coagulation, which is a signs and symptom code. They're identifying it as specific to this. So the better code would be the code that's an other code. Um, versus the R code, which is the signs and symptoms. So that first one of those first slides that I showed you with all of those bullets, almost every one of those are R codes, but these are at a higher specificity. Yeah. All right, now this was a really interesting one too. Okay, you have a patient, they get uh, admitted or seen for generalized weakness, lack of appetite, and a prior documentation of a diagnosis of post COVID-19 syndrome. Now, I don't know how many of you guys have seen that. Have you seen that code come through? Post COVID syndrome? Let me know if you guys have seen that one come through yet. Okay, so what are we supposed to do in this scenario? Again, the patient no longer has COVID, but they've got these signs and symptoms that are very specific, and the doctor has linked them. So, again, specific symptoms are going to code with the personal history of COVID-19. Post COVID-19 syndrome is just it's a history of, and it just means that it's a temporary signs and symptoms that are linked as a sequela to that. So there is not a code for post COVID-19 syndrome. It's listing the signs and symptoms, and then you saying history of COVID, the history of COVID code. All right. So that would be your Z86.16 now, and those residual effects. And then you can use the B94.8, that these are specifically linked sequelas to the COVID. So again, the main codes that we're seeing here is if you've got the current U07 code, you're not going to use the Z86.16. That's our history code. But if you do have signs and symptoms, you list those with the B94.8 because it's active. These are active late effects or sequela that the provider is stating. And then you're going to list those so that you can say, well, this weakness and stuff is related. Here was a fun one too. You got a patient, they tested negative, okay, for COVID. They in the outpatient. They end up going to the ER because their symptoms are getting worse. They end up admitting them for a possible pneumonia. Now, you might think, well, don't they know whether they have pneumonia or not? Well, now they might not, right? It's either not showing up on the x-ray yet, they can't quite hear it, but they're getting worse. So what are we supposed to do? So if they have post COVID-19 organizing pneumonia, that's a thing. And I've got some information about that on the next slide. So the pneumonia is considered, it's going to be an acute manifestation of COVID. And so it's a late effect of COVID-19, or is the COVID-19 a personal history because it's negative? So what are we going to do? Are we going to code for the COVID-19 or the pneumonia? Well, it states that there is actually a code for this organizing pneumonia, and it would be the J84.89. It's an other code. Uh, uh, let's see. How do you say that? Cryptogenic organizing pneumonia, or COP, is a specific type that's related to having other things happening in the body. This is on the alveoli, really tiny level for the pneumonia, and they have flu-like symptoms. So what we've got is this organizing pneumonia due to a past COVID-19 infection, but they don't have COVID-19 anymore. So the J4.89 is the pneumonia, the organizing pneumonia. And you'll find that where you just look under pneumonia in your index, and then it'll say organizing pneumonia. And then B94.8, because it's a sequela, late effect of COVID-19. All right, guys, that is it. Any questions that I can help you with? There is a positive antibody test that if the patient has no COVID, but they have the positive test, that would be a history of. Correct, Donna. Yeah. If the provider doesn't say they have active COVID. And I think that positive antibody test, now don't quote me on this, but I think that only lasts 6 months is what I'm hearing. Yeah. Yeah, that was a lot. You're right, Sarah. It was a lot of information. That's why I didn't make it too pretty, and I knew it was stuff that you're going to want to look at. Donna says, I've taken care of ICU patients with GB, very dramatic disease process. Absolutely, it is. Jillian Barr is scary. It more or less keeps your brain intact, but your entire body goes paralyzed. Yeah. So you can hear, you can think, but you're not able to communicate in any way for several months until that virus wears itself out. Yeah. But it is temporary. But it can take 6 months, 3 months, 9 months, a year. How would you query? We have, Sherry, some specific videos on the proper way to query. And what I would do is go to our YouTube channel. I'm not sure if that's where you're watching us from, and just type in, when you go to medical coding cert, or you're already there, in the little looking glass, type in query, and we've got a lot of education. Plus, we've got that over in the club if you're in the club. So just real quick, there's the references, and this is information about the club, cco.us/club. You get access to this lecture, you get the transcript, you get the slide deck, and then discussion and stuff over in the club. And we end up talking quite a bit after some of these lectures. Yeah. And it looks like they've put that all up there. If you're joining us on YouTube, don't forget to hit the little like button, the little thumbs up. That helps us. That lets us know. Look, there you go. Jesus already put that how to query and do a proper query is on our YouTube channel. So now you got that in there. If you are following us like Trina on Facebook, don't forget to like and subscribe. The same for YouTube. Thanks, Lori. And we've got some great stuff the rest of this week, and we are lining up some great discussions for next week too. Look forward to seeing you there. Feel free to share with other people that you're getting great great content here with us. Thanks, guys. Bye.
Do you need more medical certification and business training? Learn more at www.cco.us.